So we are live now, sir. So we are starting the session. So a very good morning to all of you. Welcome to the 8th day of Faculty Development Program organized by TLC and Department of Economics, Ramanujan College, University of Delhi. So today we have two sessions. First session is on pandemic and the opportunity to reshape healthcare system in India. We have with us Dr. Shaktivel Selvaraj sir, Director, Public Health Foundation of India, New Delhi. Dr. Selvaraj was a Takemi Fellow, postdoctoral fellow at Harvard School of Public Health, Boston, USA, and a Fulbright scholar during 2006 and 2007. He has PhD in health economics from Jawaharlal Nehru University, New Delhi. He is currently engaged in research and teaching and advocacy in the area of health system, healthcare financing, and access to medicines. He has been an expert in few government committees and WHO committees. As a technical consultant, Dr. Selvaraj has been engaged in producing and training National Health Account in Southeast Asia Regional Office WHO region. Dr. Selvaraj was the founder secretary of Indian Health Economics Association. He has published two books and has many publications in national and international peer-reviewed journals. He also contributes regularly about health policy developments in national dailies. Dr. Selvaraj contributed significantly to the development of high-level expert group report on USC. Similarly, he contributed immensely to the development of state health policy of Uttar Pradesh. Earlier, he was engaged as a health economist in the National Commission on Macroeconomics and Health, Ministry of Health and Family Welfare, New Delhi, during 2004 and 2005. His recent contributions in the area of healthcare financing include National Health Account, resource tracking, costing of healthcare, health insurance evaluations, equity in healthcare finance and delivery. In the area of medicines, his contributions include accessing financial burden of medicines to households, procurement and supply of procurement and supply chain of medicines, market structure of pharmaceuticals, drug price regulations, pharmaceuticals patents, and rational use of medicines. So, on behalf of organizing team, I would like to invite Dr. Selvaraj sir to deliver his lecture. Sir, please.
Uh, Thank you, Mr. Kumar, for that brief introduction. Before I even begin, I'm just going to put off the video because of poor connectivity and high load. So let me put off the video for some time, and then maybe if needed, I'll start off a little later. Okay, all right. I hope I'm audible to everyone.
Yes, sir. You are audible, sir.
All right. Good morning, everyone. I just wanted to, at the outset, wanted to thank Dr. Bhavna and the other organizers of the refresher course in economics for inviting me to deliver this lecture. In the next about 45 minutes or so, I have an hour. So in the next about 45 minutes or so, what I intend to do is essentially to give an idea about the current health systems in India, different features of the health systems in India. And then in the second part of my talk, I'll focus largely around the current pandemic and then the response interventions of the government and several other actors as we go along. And that's the broad structure of my presentation. And although participants will have the opportunity to interact with me later at towards the end, I will have about 10 to 15 minutes. But please do stop me, don't hesitate, do stop me if things are not clear to you so that I can try and explain. I hope, is that clear? Right, let's get started. So let me share my desktop. Just a second. Getting it. Is the slides? See the slides? No.
Yes, sir, it is visible, sir, and clear.
But is that full screen or off screen?
Sir, it is now it is not full screen. Earlier it was full screen, sir.
Just a second.
Yes, sir. Now it's full screen, sir.
That's full screen? All right.
Yes, sir.
Great. Excellent. All right. So let me get started. Okay. The starting point of my lecture this morning is about the health system. As I said, in the first half, I'm going to be focusing largely around the current health system and the kind of challenges that the country faces in terms of the health systems. Now, let me begin with saying that India is perhaps one of the most privatized healthcare market in the world. And I say this with conviction because it all through the evidence. So what I'm really going to be presenting is with a lot of evidence from the health system. So as I said, India essentially is perhaps one of the most largely private dominated healthcare system in the world, and not even US, if you think highly privatized healthcare market in the world. And the reason why I say that is that as we go along, I'll try and explain to you why this is so, both in terms of healthcare financing and provision of healthcare services. Now, just to give an idea about what this really means, if you look at two sets of dimensions, and if you look at financing, for instance, a large part of the financing is not government funded at all. Unlike other countries, even US, for instance, if you look at US healthcare system, they spend about US healthcare system spends about 18% of their GDP on healthcare. Half of it, in fact, more than half of it, is actually publicly funded. These are tax-funded money. And remember, this is in US, the mecca of capitalism. And provision, of course, although it's largely private dominated, but as I said, financing, even in a capitalist country, so this is the case. And interestingly, if you look at most European countries and then Canada, Australia, so if you look at most of the developed countries and even many developing countries, financing and provision is supposed to be largely in the government domain and some of it in the private domain. But that's not the case with India. India is traditionally, and especially in the last about 30 years, since the beginning of the liberalization, we've made health system into a private dominated oriented healthcare market. I mean, that's one of the major challenge that the country faces. And of course, we can have discussion on why. And so I'll talk about the financing and provision of Indian healthcare system and in the magnitude and pattern of healthcare financing and provision as we go along. So that's one set of issue. The second set of issue, which is which is actually linked to the first point that I made, is that when you have a largely private dominated funding and provision of healthcare services in the country, as in India, so one of the basic problem is people spend from their own pocket, and that's what we call OOPS, or the out of pocket spending. Now, this is something that out of pocket healthcare spending is considered to be one of the most inefficient and iniquitous way of spending, because you're not pooling funds and sharing risks, which is what most developed countries do. Even many developing countries like Thailand, Sri Lanka, and other countries do. And as a result of this, it can, as I said, although it's out-of-pocket way of spending is very inefficient and extremely iniquitous. And that's one of the major challenges the country faces. The third set of challenge that the country faces is, although health is a state subject, most of the delivery of healthcare services happens at the state level. It also has federal constraints in terms of national policy making. If you see, the country has come up with 3 national health policies. Central government indeed has a lot of role to play along with the state, but no doubt state governments have a larger role to play. And this itself is a major issue. And this is very clearly given the kind of role that the central and the states are subject to be playing, with a larger amount of share of states' involvement. but the central government also has an extremely important role to play, whether you talk about education, health education, or medicines, or in other categories. So the central government does supposed to play a major role, especially when you have a pandemic. The role of central government becomes even more important and extremely critical, given the coordination that's required. Now, look at oxygen supplies. After all, everything is handled. The entire oxygen supply is supposed to be handled by the central government. So the question is, so the whole role of central and state government becomes important, and that's the third challenge that the country faces. And often we see that the central government say that it's the state's responsibility. When you ask state, it says, okay, it's the central government's responsibility. So obviously we are in a conundrum there, and that's a major challenge. The fourth aspect, which is not directly related to the health system, but has huge implications for the health system in terms of the economy. Our economy is largely informal in nature. I'm sure you know the fact that if you look at the total workforce in India, so that's about 450, 480 million in India, 90% of that health work, or the total workforce, is basically in the informal sector. And that's a real challenge when you talk about insurance, because when you talk about health system, you also end up talking about health insurance. So the question is, if you want to go into a larger social health insurance framework, so the question is, do we have a large formal sector workers? That's unfortunately, given that we have 90% of the informal workforce in India, moving towards the social health insurance route is a long way, and therefore it has implications. Well, growing economy is important, but it's not matched by the formalization of the workforce, which is a major critical factor. The fifth element, again, related to the financing part. This is largely about the government financing part, which we all know that it is very rigid, little flexibility, and up to rate. So that's one of the problem that the country faces. We'll talk about it as we go along. And then the sixth element is to do with the commitment itself. Although there are aspirations both at the central and state level, governments have been promising a lot for not now, for over the years, almost 70 years. So no doubt that yes, the commitment, the so-called aspirations are there, but it doesn't really translate into tangible interventions. So you can see that in terms of low budget that the government has been providing to health sector, both central and states. So all that has implications for the health system. I hope that's clear in terms of where we are starting, in terms of the kind of current health system challenges the country faces. All right. I hope that's clear, and then let's move on. The first point, again, I talked about the financing earlier. So India currently spends about 3.5%, on an average about 3.5% of GDP on healthcare. Now, as I said, look at countries like US, which is an outlier in terms of healthcare spending. They spend about 18% of GDP, almost 1/5 of their GDP is spent on healthcare in US. So look at the kind of inefficiency there that they are involved. And look at the other developed countries such as UK, France, and other European countries, and even Canada and Australia. On an average, if you look at these countries, developed countries, except US, which is an outlier, as I said, they spend about 18% of GDP. But most other developed countries spend on an average about 9 to 10% of GDP. So that's about 1/10 of your GDP goes into healthcare spending, against double against the double OECD average in US, which is 18%, almost 1/5, as against 1/10. Now, what do we spend in developing countries, and especially in India? On an average, developing country spending is about 5% or so of GDP on healthcare. India spends about currently 3.5, anywhere between 3.5 to 4% of GDP on healthcare. But the question is not about the size of that. The issue is really about the distribution of that funds. What is the distribution? So the distribution, when I say distribution, although 3.5–4% of GDP is spent on healthcare in India, but in terms of who spends becomes important. As I said earlier, whether it is developed country, whether it is capitalist country, a socialist country, a lot of money is spent. In fact, a larger share of funds, a proportionately larger share of funding is comes from the government in most of those countries, even in capitalist countries. Now, what do we do in India? Traditionally, in the last about 70 years or so, until now, on an average, if you look at those 4% of GDP, just about 1% of GDP is actually spent on healthcare by the government, both central and states put together. Right? So that's a basic challenge. And so what happens? The rest, a large part of it is almost 63, almost 2/3 of the funding comes from the households, you and I, from our own pocket. Households, that's called the households out of pocket spending. So which is extremely high, as I said. No country, I can't think of any country. So if you rank countries around the world, 190 countries around the world, and then rank in terms of how much each country spends in public spending on health, India would be around about 185th or so out of 190 countries in terms of public spending on healthcare. And that's the tragedy that we all see in here in Delhi, the so-called capital of the country, the kind of tragedy that's unfolding before us. Why? Because of for traditionally for so many years, we have not done anything about the public health system, and that's and we're facing that the brunt of it. All right, so let's move on. In terms of so that's in terms of the larger indicator, but in terms of the per capita spending, if you like, on an average, just about 3 years before in 17 and 18. On an average, the per capita spending on healthcare is about 4,297 rupees, out of which the government spending, both central and states put together, is about 1,700. And then, as I said, the largest component is about a little over 2,000 rupees per capita is from the households out-of-pocket payment, which is the largest component. And then what about the other spending pattern? You might be interested to know that insurance, that's private health insurance, contributes to about 4 to 5% now. And then, well, external donors. This is again very interesting. Even now in India, World Bank and many other players, technical players and non-technical players, still play a large role in our health policy formulation and design and interventions. But look at their contribution, just about 5%, 0.5%, just about 0.5%. And yet you see a lot of their influence in policy making, shaping policies and design of health care system. So that's it's a bit unfortunate, and it's been continuing for a long time. So we can come back to this in case if you need any assistance in terms of understanding this. The one that you see up there, I call it as NHA. It's basically the National Health Account. So the entire numbers, the number that you see up there, all derived from the National Health Accounts the country produces. All right. So let's move on. So what does it really mean? It means that the risk pooling in India is hugely fragmented. What does it really mean? It means that in countries like, for instance, US, or okay, let's look at other European countries. In most European countries, either large part of the healthcare system is funded either by the taxes or by the social health insurance system. What does social health insurance really mean? Social health insurance really mean that the employer, employee, and then the government share funds so that the funds are utilized by the community, by the people at large. Okay, so that's what social health insurance really mean. So half of the European countries, for instance, OECD countries, not European, but OECD countries rely on social health insurance, and about half of them rely on tax-funded money. For instance, UK. UK's health system is supposed to be the NHS. You must have heard about the National Health Service in UK, considered to be one of the best system in terms of health outcomes. They spend about 9 to 10% of their GDP on healthcare. Now, if you look at that, 85%, 85, 90% of that funds actually is tax funded money. So that's government funded money through the taxes, right? So all that is called risk pooled funds. So what is risk pooling? It's an important concept in insurance. So risk pooling essentially involves sharing of risks and resources by the society. So look, for instance, in any society, any country, you would have the rich, the poor, the healthy population, the sick population, the productive population, and then the dependent age population. Now you need to mix these population groups in order to share risks and share funds. So when people need it, they can use it, and then the others will continue to contribute. For instance, some of the dependents, those who can't earn less than, let's say, 18 years of age, and those who are above 60 years who can't earn, they are dependent on this population. So essentially, the dependent age population end up paying for the rest of it. And that's the way the social health insurance, or any health insurance for that matter, functions. So this is this whole idea is called the risk pooling, which is important because risk pooling is not only important in terms of equity dimension, but also important in terms of the efficiency. Risk pooled funds are much more efficient than paying households out-of-pocket payment. As you can see on the right-hand side of the graph, you can see that not pooled is about 2/3 in India. So that's highly inefficient way of funding. And if you look at this pooled funds, on the one hand, you have public subsidies on the right-hand side, which is basically the government spending. And in the middle, you have, again, pooled funds, but these are contributory in nature. So employers and employees contributing. Now, ESIS is a very classic example. ESIS is nothing but the employee state health insurance scheme, where both the employer and employee in the formal sector contribute towards social security scheme, including health insurance. And then they and their dependents can take benefit all through their life. I mean, that's what social health insurance is all about. So ESI is a typical social health insurance model. It currently covers about 132 million people. So I'll come back to this a little later. So the point is, if your risk pooling is fragmented, as I said, it is inefficient and iniquitous way. Given that India has a highly fragmented risk pooling and people end up paying a lot of money from their pocket, as I said, it's inefficient and iniquitous. Our own estimates suggest that there are about 55 million people in India. This is before the pandemic. Every year, on an average, no other country has this kind of a distinction, a dubious distinction of 55 million people are being pushed below poverty line just because we have to pay from your own pocket. So that's a lot of people who are pushed below poverty line because the government doesn't spend money. So that's the major issue. The other issue is, even if there are people who are paying, they end up what is called catastrophic payment. So if a household end up spending more than 10% of their income, annual income on healthcare, then that's considered to be catastrophic in nature. So almost 18% in India are pushed into that kind of a category. So that's the reason why I wanted to focus here is the fact that the kind of financing mechanism that we follow has implications both in terms of impoverishment, catastrophic payment. All right, let's move on to the provision aspect. I talked about the financing aspect. I'll come back again to the financing aspect a little later. Let's look at the provision. How does the provision in India happens? Interestingly, so as you can see, expenditures by the provider category. about one third of the funding goes to hospitals, private hospitals, and about the government hospitals accounted for about 18%, and the others. So in terms of the functional classification, as you can see, outpatient or OP care is nothing but the outpatient care, which is the largest if you add that with medicines. I'll come back to this aspect a little later as we go along. And then inpatient care, that's IP care, is nothing but the inpatient care. So those who require hospitalization is called the inpatient care, accounts for over one third of the total spending in terms of the functional classification. I'll come back to this. But the larger point, okay, I just wanted to just don't understand why this is not coming up. So I'm sure if you have your slides and print out, you can see that there are both sides. I can only see one side of this PowerPoint here, but I can explain to you what this really means about the both these sides. So in terms of the delivery of healthcare services, it's interesting to note that now look at this on the one on the left-hand side. This is for the evidence from 1718 National Sample Survey. What does it suggest? It suggests that on an average, if a hospitalization takes place, it's likely that about 58%, almost 60% of the hospitalization actually happens in the private sector. All right, on an average. So that's an important point. So the reason why I said again in the first remark that I made when I began, India is not only in terms of financing very highly privatized, but also in terms of provision of healthcare services. India's healthcare system is highly privatized. So the one that you see on the left-hand side is basically the hospitalization, and one on the right-hand side you see is the outpatient care visits. Now the outpatient care visits are very clear, very extremely clear, where 70% of all the outpatient care visits, suppose if I have cold, cough, fever, and if I go to a clinic, private clinic, then that becomes outpatient visits, right? So 70% of the total outpatient visits happens in the private sector. So what it really means is only about 30% of the outpatient care visits happens in the government facilities. The one on the right, on the left-hand side, as you can see, is basically the hospitalization, the percentage of hospitalization. Nearly about 60% of all the hospitalization in India happens in the private sector. Just about 40% of the hospitalization happens in the government sector. So this is a clear indication why I said the healthcare delivery system is highly privatized in India, and it has implication. The reason why I'm saying is that it has implication both for efficiency and as well as for equity dimension. Now, having said that, look at the delivery of healthcare services, both in terms of inpatient and outpatient by different states. It's interesting, as you can see, by different states, it's clear that there is no clear pattern emerging. But the important point is there are many states, states like Telangana, Maharashtra, Karnataka, Uttar Pradesh, including Andhra Pradesh, Punjab, where the hospitalization, a larger part of the hospitalization, almost close to about 80% of hospitalization in Telangana and Maharashtra, which is their very highly privatized market, is in the private sector. So look at, on the other hand, go down below, you will see that states like Assam, Odisha, Himachal, for instance, Jammu and Kashmir. Now, if you look at those states, the hospitalization, so now if you look at the total hospitalization, just about 30% of the hospitalization happens in the private sector, but almost 70% of the hospitalization actually happens in the public sector. So that's the kind of kind of a privatization that has happened in the in the health care sector, although it's highly variant across the country by different states. And that's equally true of the outpatient care visits that you can see on the right hand side. I hope that's clear. Okay. If that's clear, let's move on to some of the schemes that in India has. India, of course, has different schemes. I'm sure you must have heard about the National Health Mission. National Health Mission is basically a central government scheme. It has national coverage. It's the funds for this National Health Mission is basically it's a mixed funding where for most of the states, that's basically states which are non-focus states. 60-40 is the kind of a ratio where 60% of the money comes from the center and about 40% of the money is funded directly by the state government for the National Health Mission. Okay, this is supposed to be national in character, and the money is basically sourced through tax and non-tax funds through the budget. And then you have the public health system at the state level. These are basically state-funded and state-provided healthcare services. These are notionally supposed to be universal in nature. So if I go to a public health system, I'm expected to get everything supposed to be free. But we know that that's not the case. It's supposed to be, everything is supposed to be available and supposed to be free. So that's why we call it as universal. But these are all notional. The moment you go there, many of the services are not there. Even if they're available, then you'll have to end up paying, or you have to end up, for instance, in many circumstances, in many states, you end up paying from their own out of pocket. Even if you visit public health system, they'll say they don't have medicines or diagnostics, so you'll have to go out of the government system to get those services. So I mean, that's about the public health system. And there's a social health insurance system that I talked about in India. Two major schemes. One is the ESI scheme, which is the largest scheme, which covers about 132 million population. So this is basically the formal sector employees and their dependents. So that's the ESIS, which covers. The interesting thing about ESIS is it's just not only curative care in terms of inpatient and outpatient, but also provides a lot of preventive care services. So that's a very interesting, in fact, not only inpatient, outpatient, and healthcare services, it's also one of the most highly, if you look at in terms of benefits, one of the largest scheme and also one of the best scheme in the world in terms of benefits. So it provides maternity benefits, and it also provides morbidity. If you're sick for a month, let's say, you get paid leave. So in a sense, this ESIS is one of the largest and the best scheme in the world, although not doing very well. And then in addition, in the last about 13 years or so, beginning from RSBI at the central level and then Arogyasri in Andhra, we used to have something called the RSBY, which is used to begin centrally sponsored scheme of the central government. This is basically the government-funded health insurance scheme. Now that's in 2018. It has taken a different name called PMJ. So that's the Prime Minister's Jan Arogya Yojana, which is basically the tax-funded health insurance scheme. So basically, government-funded health insurance scheme. All the premiums are paid by the government directly. This is again, this scheme, PMJ scheme, is a centrally sponsored scheme with a 60-40 division ratio between center and states. The states contribute about 40% and center contributes about 60%. But this is in non-focus states. If you look at high-focus states such as UP, Bihar, and many other states, even northeastern states, the ratio is 75-40-25, wherein 75% of the funds come from the center and about 25% from the states. So that's what the PMJ currently is all about. Now let's look at okay. Let's look at this part. Now, interestingly, if you look at the different insurance schemes, because I'm sure you might be interested in understanding what this really means, There are several insurance schemes in India. I'm talking about the health insurance schemes. The one on the toward the end is basically the PMJ. Spent about 1,400 million. Last year it was the budget allocation, in fact, this year was 6,400 crores. Even last year, the allocation was about 6,400 crore, but unfortunately ended up spending only about half of it, PMJ. So the utilization is very, very poor, even last year, and this year is supposed to be even lesser. Now look at the other schemes, and it's interesting. The reason why I'm bringing this up is interesting. PMJ is supposed to be covering about 500 million people. So intentionally, it has a good scheme in terms of intention and design. But look at some of these per capita spending, very low per capita spending, just about USD 3. If you translate that in terms of the rupees, so that's about 200 rupees, right? So that's a paltry amount of money in terms of per capita expenditure. But of course, in terms of the intentions, no doubt, covering 500 million people with, 6,400 crore is just nothing still. But look at, for instance, ESIS, which is basically funded by employer, and to some extent by the government. It covers about 133 million, but look at the spending, almost double than that, much more double than this. As a result, you can see that close to about $30 are spent. So that's about 2,100 rupees per capita. But the point is, now look at CGHS. Now CGHS is an interesting case. Now these, I'm sure you must be knowing what the CGHS really means. The central government health scheme. These are largely, with except some little bit of payment premium, that's not even called premium, some amount of money, but largely most of the CGHS funds are tax funded. Now look at this, only about less than 3.5 million people are covered, but look at the amount of money spent on them. Remember, what the CGS scheme is all about? Central government employees, including the bureaucrats, the judges and whatnot, all of them put together. And look at that. Look at in terms of the kind of spending. One of the most highly spenders in terms of per capita spending, USD 115. So you're talking about 8,000 rupees per capita spent on each CGHS and just rupees 200 on a poor family which accesses PMJ. And this is the kind of anomaly that we see in budget formulation. So I'm just trying to bring in the kind of inequity that exists with all kinds of aspirations and commitment, so-called commitment that our leaders have. Okay, just two other points that I wanted to bring in is that I guess I have 10 minutes, so I'll have to just rush now. Okay. So in terms of, so ideally, if you look at the way the states have developed over the years, you would notice that state development can be, one of the measurement is through GSDP, that's gross state domestic product. Now, if you look at the way state governments have developed in terms of development paradigm, if you look at through the GSDP indicator, you know that, I mean, all of us know that, for instance, Bihar and Uttar Pradesh, for instance, Uttar Pradesh's per capita GSDP, that's per capita income, is just about 50,000, just about 2 years before, 50,000, against, let's say, Kerala and Tamil Nadu. Now, Kerala and Tamil Nadu, the per capita income is about, so that's about 2 lakh and 40,000, right? Against 50,000 in Uttar Pradesh, for instance. So what we are really looking at is about 4 to 5 times a higher per capita income in states like Tamil Nadu. I'm only looking at some of the largest states. Look at Kerala and Tamil Nadu, whose per capita income is almost 5 times more than what one would earn in Uttar Pradesh and Bihar. Now look at, if you fit a trend line here, and then look at how much those states spend on healthcare. This is public spending on healthcare. So very clearly, you can see a clear correlation of upward trend, where positive upward trend, where states like Bihar and Uttar Pradesh, on the other hand, where because their per capita GSDP is low, their per capita spending on healthcare is also low. On the other hand, Tamil Nadu and Kerala, whose per capita GDP, that's per capita income, is 4 to 5 times higher, you also see that the per capita income spent on healthcare by Kerala is much, much higher, almost 4 to 5 times higher than Bihar, UP. And similar to do with the per capita expenditure. So if you look at per capita general government expenditure, similar trend emerges in terms of, because what it really means is that if a particular state, Kerala, Tamil Nadu, or Punjab, has larger GSDP, what it also means is that their spending pattern is high because they are able to mobilize more taxes from their own tax revenue. So if they have more tax revenue, obviously they will be able to spend more. That's what you see in states like Kerala and Tamil Nadu. On the one hand, you have Uttar Pradesh and Bihar, who doesn't spend much money because they have less taxing capacity, and as a result. But having said that, there are outliers. Look at states like Punjab. Now they're much more, almost equal or much more than Tamil Nadu and Kerala in terms of per capita GSDP, and yet they're spending less. Haryana, Punjab, for instance, they should be spending more than Tamil Nadu and Kerala because of per capita government expenditure, and also GSDP. They are much higher than Tamil Nadu, or little equal to Tamil Nadu and Kerala. They should be spending more, Punjab and Haryana, but that's not happening. So these are anomalies that I wanted to point out. This is just another important evidence that I think we must understand. Initially, I talked about households, high households out-of-pocket payment. If you look at countries around the world, globally, it's interesting to see India is just right on the top. Blue color, the big blue color, and followed down below by China. In terms of households out-of-pocket payment, over the years, say 30 years before, both India and China were in the same position in terms of households out-of-pocket payment. 65% of our healthcare spending used to come from households out-of-pocket payment. But look at the last 30 years, China's gone down. It's big, no doubt, like India, in terms of population, but just gone down in terms of the households out-of-pocket payment. So they've done quite enormously in terms of public spending. They've increased public spending substantially in the last 20, 30 years. The reason why I'm just wanting to have this comparison is that we can only compare with China because of the population size. And remember, both of us, China and India, started together both in terms of GDP as well as other social indicators. Now look at them. They've gone far ahead. I'm going to skip some of the PMJ. I wish we had time to discuss more about the PMJ scheme, but I know that I'm sure you must be knowing that PMJ is one of, as I said, covers about 500 million population, supposed to be covering about 500 million population with about 1,500 plus procedures, covering about 24 specialties with no cap on family size and age agenda. It's supposed to be cashless and paperless, and a maximum cover of 5 lakh rupees per family per year. So remember, the premium is paid by the government. The entire premium is paid by the government. On an average, the premium varies between state to state, anywhere between 400 to 2,400 rupees. So this is now, I think 33 states now follow that scheme. There are about 24, now currently about 25,000 hospitals are empaneled. So all that looks very gigantic in terms of the numbers. But the real problem, as I said, is about this inequity in terms of spending. Despite all the commitment, what is the actual spending and allocation and spending? Just about 200 rupees per capita for the PMJ scheme. So, I mean, that very clearly shows where the commitment is. And look at CGHS, for instance, which is about 8,000 rupees per capita. Okay, just to, I wanted to, I think, need to go into the other aspects of the pandemic now. Okay, two other things that I wanted to touch base because we're looking at the workforce. Also, in fact, two systems or subsystems that India has actually had the advantage, but given our way of poor planning and weak planning, we couldn't do much for our own population. The reason why I'm saying is that two sets of themes. One is the workforce, and then the next I'm going to talk about the medicines. Now, in both medicines as well as workforce, we had an advantage. India produces a much larger workforce, health workforce than any country. But what is happening? But look at this. In terms of active health workforce, we're still way below. Just about 0.8 million allopathic doctors and about 1.4 million nurses. Currently, they are active. Although the actual number of people who are registered are much more than this. But in terms of active health workforce who are actually in the health system is much lesser. So that's about 0.8 million doctors and about 1.4 million nurses and midwives. So if you look at the global average, the threshold, the global WHO threshold is 44.5 doctor, nurses, and midwives per 10,000 population. So this is a rate. This is how ideally it should be. But what is India's density? It's just about 5 doctors and 6 nurses and midwives. That's about 11. So 11 doctors and midwives per 10,000 population against the WHO threshold of 44. So almost we are way below in terms of the global threshold. So we still lack a lot of them. But even if you have them, the problem is, of course, one is the a significant number of the, especially the doctors and specialists go out of the country. And even those who remain in the country, what happened? Bulk of them, both doctors and nurses, are largely located in major metropolitan cities and other cities, which leaves only a very significant, a huge gap, both in rural and urban areas. And that's the reason why you don't see doctors and nurses going to the rural areas, and a huge challenge in those areas. Interestingly, almost half of the doctors are produced by the government medical colleges, but 80% of them are employed in the private institutions. Now look at how the entire resources are being mismanaged, right? And we don't have that kind of capacity to absorb them with good incentives. I mean, that's one of the key challenge. Unfortunately, a sizable proportion of technically qualified individuals are also not in the health workforce. So that's one challenge. In fact, we have an advantage, but we are unable to turn that advantage into a reality. And that's also true with the medicines. India is the global pharmacy. I'm not sure whether you know the fact. I'm sure many of you know the fact that India is one of the major medicine global pharmacy. So we produce almost half of what we produce is actually exported to 190 countries around the world. I'm not sure whether you know the fact. So we have about 10,000 manufacturing units in the country, producing about 2 lakh, close to about 3 lakh crore of medicines. Half of it is actually exported to 190 countries around the world. And yet, a large proportion of our own population do not have access to medicines. Why is that so? So I think there's something wrong with the way we, work. Our supply our procurement system is inefficient. Our in the government system, our logistics supply system is extremely unreliable. Our pricing. Interestingly, if you look at Indian medicines, if you go out of India, for instance, Sri Lanka, or many other countries, including many other countries around the world, you would see Indian product much more cheaper there than Indians buying it in India itself. So we produce it to the world much more cheaper, and yet our own affordability to medicines are much more higher. And that's the tragedy. We are a major global pharmacy. That's an issue. And there are other issues such as the way we use medicines are extremely irrational, which leads to what is called the antimicrobial resistance and so on and so forth. Huge problems. So that's again a huge regulatory failure. A lot of regulatory failure, which is now, we're all seeing it now in the pandemic, how regulatory failure is completely, just entire regulation is collapsed in the country. Okay. So let me, as a result of it, you must have seen the news item a couple of days before. So a lot of intermediate items to produce medicine, I mean, unfortunately, they are all 70% of them are imported from China. Now look at that. Because of the disruption and supply chain, the prices of those raw materials has gone up in a big way, which is now affecting pretty much every other medicines needed during the pandemic. Their prices are going to go up in a big way. Unfortunately, this is the reality. Now, okay, I know just I realize that I've left with just about 7 minutes. Is that true, Mr. Sonukumar, Dr. Sonukumar? Or do I have a little more time?
So, sir, we have a little more time. So, our second session is from 12:30. So, we can
All right.
extend
To
few minutes.
12:10 or so.
Uh, yes, sir. We can extend this session, sir.
All right. Thank you. Thank you so much. I have just about 4 or 5 slides. Just try and wrap up now. I think the point about when the pandemic began last year, the point about lockdowns are all known. I'm not really going to go into the impact. I think impact is all known now. India is now the second most affected countries in terms of the pandemic. But one of the points to remember is the lockdown. I think the lockdown is one of the most stringent and the longest lockdowns the world has ever seen for almost 40 days. But what is the net impact? The net impact is our GDP is now washed out. Never in the history of India's independent India, India's GDP went down to a negative category to almost 20%. So I can't think of any other year where GDP was washed out this way. And I think this year we are looking at even further damage to the country's thing. As a result, of course, we saw the kind of horrendous stories last year, and I think that's even repeated now in terms of informal workers losing their jobs and wages. So I think those are really, really a major concern. But in terms of the health system, yes, no doubt, since last year, we've really ramped up a lot of things, including testing. For instance, we had just about 52 facilities when the epidemic began. Now we have 2,500 facilities which can go and test COVID testing. And even in terms of number of beds and isolation beds and oxygen beds, it's all gone up. But the problem is, do we have oxygen? Even if you have oxygen support beds, that's the tragedy that we're sitting in. Okay, one of the impact as a result of the COVID last year. Now, this is just 6 months old evidence. One of the things that we also noticed is, while it's not only the fact that the COVID has impacted every other sector, including hospital sector, one of the things that we also noticed is that both in terms of the demand side as well as the supply side, the huge disruption to not only COVID services, but also for non-COVID services. Now, hospital activity itself dropped by about 49% and about 37% during late lockdown. So that's in terms of the supply side. So most hospitals were locked, or even if they opened up, There was hardly any other services for non-COVID services from the supply side. From the demand side, there are a lot of fear and stigmatization that was going on. So people were unwilling and uh, scared of going to use even outpatient care services. As a result, service utilization declined sharply during lockdown, even after the late lockdown. From the point of view of demand side, there was a huge drop in service utilization. Now, all this has implications to both emergency utilization as well as non-emergency services, including TB, HIV, malaria testing and treatment and prevention activities. All these have suffered significantly. One of the other things that is also happened last year and happening in a big way now, given that many state governments have gone into lockdown mode, there's a significant decline in immunization coverage, and there's a huge rise in home-based child births. Now, interestingly, since the beginning of National Health Mission in 2005 until last year, the institutional childbirths have gone up tremendously, about 94-95%. But I think last 1 year, especially in the last and last 1 year or so, more than one and a half years, institutional childbirths have taken a big hit. So a lot of childbirths are happening at home. Now, remember the fact that when childbirths happen at home, risky childbirths are happening. So a lot of issues of even saving the mother and the child becomes critical. And those are some of the setbacks that the health system has suffered because of the lockdown and the pandemic. Okay, last two point about what did the government do in terms of interventions. Now, interestingly, if you look at the 21-22 budget that was presented in March, the central government allocated about 77,000 crore rupees as against about 72,000 crore. That's a revised estimate. The one that you see in the slide is 69,000. That's only budget estimates. But if you look at the revised estimate, that was about for 2021 was about 74,000 crore. So in a sense, the actual allocation was only a very marginal increase. Now remember, this is happening in a pandemic year. There's hardly any increase. In fact, NHM, which is supposed to be the flagship program, saw only a rise of only 4% allocation. Even for PMJ, which is supposed to be the government's the pet project, the allocation just remained the same. Last year's allocation was 6,400, and this year's allocation is also just the same. In fact, if you look at last year's allocation, which was 6,400, but the utilization just was about half of it, 50% utilization. So that's the major problem. And therefore, even if you look at the allocation for this year, this is considered to be business as usual scenario. So we're really not done anything great in terms of the pandemic budget. Yes, one thing that was really done in a big way, at least in terms of allocation, now we're seeing what is happening to that. Is that the allocation for vaccination is a one-off allocation. 35,000 crore was set aside for vaccination. Now that's the reason why you see in the initial stage of the vaccination, the entire vaccination was procured and distributed at the state level, although it was procured and financed by the central government. So ideally, one would have expected this to continue, but I don't know, suddenly there's a turn of events in the last about 1 month. Say now the central government is saying, let the state government take the role of even financing. This is even interesting. It comes at a big surprise, given that there is a 35,000 crore allocation for vaccination in the budget. I'm not sure what is really happening, which is a major setback despite the allocation. The other point is about the budget also contains some good allocation. That's largely to do with the Finance Commission grants. So you must have heard about there's a new Finance Commission grant that has come into 15 Finance Commission. Looking at the pandemic, the 15th Finance Commission awarded an unconditional grants to state governments. So that's about 20,000 crore per annum for the next 5 years, which I think is a good beginning. In addition to what the central government is spending, I only hope they don't substitute one for the other. So that's an additional allocation. And if these allocations were to be utilized, one can expect some bit of improvement in terms of the primary healthcare services and also secondary care services. Now, let's move on to vaccine and medicines. Now, interestingly, as I said, if you want to do a universal vaccination of COVID, at least for the adult population, you need about 1.7 billion doses to vaccinate the entire country. Currently, we are about 152 million doses. That's about close to about one-tenth of the total vaccinated doses. You might remember that in India currently, if you leave Sputnik, which is just still being imported, there are only two vaccines, Covaxin and Covishield. Now, Covaxin is basically currently produced by Bharat Biotech. It's an Indian company. Now, interestingly, this Covaxin is basically discovered by the ICMR and Bharat Biotech. So it's basically a joint venture between different players, including, remember, this is funded, the discovery was funded by the government. But unfortunately, only one company got go ahead to produce it, which is very unfair. Given that we have huge shortage, ideally it should have been thrown open to other Indian companies as well, both public sector undertakings as well as private companies. But unfortunately, that's not happening. So that's an area of concern. The other thing is Covishield. Now, Covishield is basically it's AstraZeneca's vaccine. Although AstraZeneca has a tie-up with Serum Institute, India's Serum Institute, they have a technical collaboration, and ultimately most of it is produced in Serum, and Serum can only export it and then supply it to the domestic industry, domestic market. Now, interestingly, if you look at India's vaccine production and supply, interestingly, even before the COVID vaccines, if you look at the rest of the vaccines, the primary universal vaccines, 60% of vaccine requirement globally is all met by the Indian companies. So that's the kind of production capacity that we have. But unfortunately, I think currently only two companies only the government knows why only these two companies are being given that kind of a thing. I can understand about Covishield because that's an arrangement between AstraZeneca and Serum. But I think the reason why I'm saying is that there are public health measures that can be invoked. For instance, there's something called the compulsory licensing that can be invoked. So there is international agreement where sovereign country like India should invoke those licensing, compulsory licensing arrangement, where it can ask other Indian companies to produce Covishield. So all that is possible. The Indian Patent Act allows that, and we have the flexibility to use it. But unfortunately, not sure why this is not being done. And ideally, it should be done in order to increase vaccination, universal vaccination of COVID vaccines. Similarly, you would see there's a lot of shortages of many critical drugs, including remdesivir, favipiravir, tocilizumab, and several other new drugs that's coming up. Now, why is this so? Because there are only, but even before I go further, I must caution that you don't need remdesivir and other, especially remdesivir and others, in the outpatient care setting. Only hospital-based intervention, remdesivir is usually used. But unfortunately, in our country, everybody uses it left and right, even in an outpatient care setting, in a home-based care setting, which you can't do it, not supposed to be using it. And that's one of the reasons why you see the prices of remdesivir, for instance, which is just 700 rupees per vial, 750 rupees per vial, is being sold in the black market around the country for about 75,000 per vial. Remember, 5 to 6 vials have to be used for a hospitalization case. Now, how many people in this country has that kind of a money to do it? And that's the reason why people go around begging and borrowing, getting this drug for administering it. So the point that I'm trying to make is we have a lot of public health safeguards available in our patent system. Unfortunately, in this country, a country which has so much capacity, but we've just not been able to use it because of the huge pressure from US and other developed countries for not using, against using compulsory licensing. Now, when it comes to their own country, US and America, Canada and other countries, they've always used compulsory licensing when it needed for their own population. But when it comes to India and our own country's own, we have the capacity, unlike other countries, we have the capacity and we should be doing it. But unfortunately, these countries are just not allowing us to invoke those provisions. India has done it only once in 2012 for anti-cancer medicine of compulsory licensing. After that, the US and other countries just not allowing us to do this at all, despite the fact that we are a sovereign country and we have the flexibility. Globally, this is all accepted. So I think that's the tragedy of policy making. We just don't take it for our own country. It's all about pandering to other countries' interest. Okay, now before I conclude, just last two slides. One question that's being asked regularly with me, and in fact, many people look at this aspect, is that our health system overwhelmed? If you look at the current second wave and the kind of interventions and responses, or is it sheer incompetence? I mean, that's a point I think we need to really look at. We know during the first lockdown, there was hardly any preparations, which inflicted huge economic damage, both in terms of jobs and income. And remember, the first lockdown was supposed to ramp up. The lockdown was needed to ramp up health system and spruce up production capacities. What's happened to those point about ramping up production as well as production capacity of oxygens and medicines and other things? Now look at the second wave, which is completely caught unawares, and we are happily going around doing election rallies and religious congregations, whatnot, which fueled the rapid spread of the virus. I think it's too little, too late response. The governments have completely abdicated responsibilities, poor planning and weak response, I think. And the major thing is regulatory failure, complete regulatory failure. Remember, this is not like any other commodity. There's a healthcare with asymmetric information. When there is asymmetric information with a large private sector dominated healthcare sector, they would do all kinds of rent seeking. And that's the reason, remember, remdesivir is being sold 750 rupee, remdesivir one vial is sold at 75,000. Oxygen cylinders, even if you want to just get a one oxygen cylinder filled, which is just about 300 to 150, 200 rupees before the second wave began. Now you're getting it for 10,000 rupees. Where is the policy? Where are the interventions? And ultimately, the reason why I wanted to conclude this is all this is simply because of the simple belief in the last 30 years of whichever government is, the simple belief that the market system can take care. But we know that it has completely wreaked havoc. Okay, what are the potential prospects and challenges that we are still facing in terms of different healthcare system components? Health financing, I think I don't really need to repeat what I said. The current level of government funding is extremely poor. We need to at least go up to a high level of public spending. A high dependence on households out-of-pocket payment is just not is inefficient and inequitous. Access to medicine, as I said, India is a global pharmacy, and yet a lot of people are still not getting access, especially in the pandemic situation. A lot of even common medicines are going out of circulation, which is a major. So, what is regulation? What is regulation doing? And that's where the whole problem is. Poor regulation, and even in a pandemic situation, you should be actively regulating. Actually, what is happening is a laissez-faire market. They left everything to the market to decide. And that's what you and I are facing, the kind of challenges, the brunt of challenges are faced by you and I. Look at health workforce. I talked about it earlier. There's a huge flight of medical professionals to other countries, but there's also a huge skewed distribution of those health workforce within the country. Of course, limited production is one of the issues. The problem with service delivery in our country is a large, because it's a private dominated, they're more focused on curative care. If we had invested heavily on preventive and promotive care, we would have actually prevented a lot of deaths and the suffering that people are facing in a pandemic. And that's the challenge, one of the major challenges that we're facing. Health information technology, yes, it's useful. It can leapfrog. It can, e-health and all that is going to be helpful, no doubt. I think we need to use those to circumvent some of the challenges. But let's not forget, all that is okay in terms of health system, but health care is actually influenced by not health system alone, but the social systems. So what it really means is that the conditions in which people are born, grow, work, live, and age has implication. So there is a wider set of forces and systems shaping the conditions of every life, including economic policies, social norms, and development agenda. All this has implications to the way our health system functions. So obviously you can't change that overnight, but a lot of things can actually be changed. Let me wrap up the last slide. I think there is a need to basically move away from a fragmented health system to a more predominantly, from the currently predominant healthcare delivery system. I think there's a need to move away to a large public health system with more preventive and promotive care. The need to universalize healthcare is far more urgent than ever, of course, with a focus on preventive and promotive care delivered by public health system. So one of the other things that we also keep telling is, even during the pandemic, if the pandemic were to prolong, I think one of the things that we really need to look at is that we need to place significant, it is going to place significant strain on non-COVID services, which will have huge implications on the outcome. So for instance, the childbirth that I talked about, institutional childbirth that I talked about, immunization coverage, TB, malaria, for instance, we're all, so because of the pandemic, all this getting sidetracked, which has huge implications. And we need to look at that as well. And I think two things, finally, let me finish. Two things are needed. One, we need to improve governance. Just without improving governance, we can't do anything about it. But along with governance improvement, you need public funding. The current public funding of 1% of GDP is just too low. At least 2 to 2.5% of GDP needs to be spent on public health. Both central and states should be spending more money and efficiently. I think I'll stop there. Thank you.
Thank you, sir, for covering this
Sorry
health issue.
I know that it took longer than expected.
No problem, sir. Sir, can you take a few questions, sir?
Please go ahead. I'm free for the next 10, 15 minutes. Yes.
So, sir, first set of question is, how is your experience with government hospital in India? I always felt very sad after seeing situation in government hospital. सेकंड क्वेश्चन इज रिलेटेड टू इट. प्राइमरी हेल्थ सुविधाएं प्रोवाइड करने की सरकार की जिम्मेदारी है, लेकिन इसमें पिछले 6-7 दशक में कोई खास बदलाव नहीं आया है. इसमें सुधार लाने के लिए गवर्नमेंट को क्या करना चाहिए?
Okay, two things. Okay, government hospitals. Yes. So the point is, we all want to go to the government hospitals for several reasons. Am I audible?
Yes, sir, you are audible, sir.
So no doubt we all want to go to the government hospitals, but the reason why we can't go, many of us don't go, is simply the fact that the services are poor, and not all services are available, number one. And then the way people are treated, given that the health workforce is also strained, overworked. So think of a situation. Now, let me just give an example. Think of a situation when you go to a private clinic. How many people do you see? 10 people? 15? 5 sometimes? On an average, 5, 6, 7, 8. Now you go to a hospital, you go to a primary healthcare center. I don't know how many of you have gone to a primary healthcare centers. You don't have to go to a rural area, just close by. Go to a primary healthcare center. On an average, in a well-functioning primary healthcare centers, you would get on an average about 200, 250 persons a day. Remember, they're only working for 8 hours. Now look at that, and look at the number of people visiting private clinics. So number one, there's huge stress on the workforce that we have, especially in public health systems. So remember, one doctor is just managing, and what would you expect a doctor to spend on? So hardly he or she would spend about 2 to 3 minutes, even less, in a public health system. Unlike if you go to a private healthcare system, you would expect, for instance, in a clinic, private clinic, you would at least expect the doctor to speak to you and then spend at least 10 to 5 minutes, 15 minutes. So that makes a lot of difference, no doubt. And two, the other problems are medicine. Now, medicines and other diagnostics. If you leave out 2 or 3 states, Tamil Nadu, Kerala, maybe to some extent, Himachal, Rajasthan. If you leave out these states, if you go to most other states, including Delhi to some extent, it's much better. What do? You go get the consultation, but unfortunately, in many of these public health systems, you don't get medicines free, you don't get diagnostics. So you'll have to again go out with a doctor's prescription, buy medicines outside, get the diagnostics outside. So the question is, we've faltered on all this front in terms of procurement, distribution, diagnostic facilities. So unless, as I said, unless we improve the governance within the public health system and pump in a large amount of money, things are not going to be good enough to visit. But having said that, now one may have problems in and the long queues and all kinds of, they're not good quality. Well, quality can have a different dimension. If you're expecting clean, and of course you need clean floors and so on and so forth, but you don't need 5-star facilities, right? I mean, this is the real difference between public and private facilities. So our expectations also important to consider. But the point is, now you go to some of these states, Kerala, Tamil Nadu, for instance, or even Himachal to some extent. You go to those public health institutions, primary. Let me only pick up only primary healthcare centers. Some of the primary healthcare centers, you wouldn't believe, it'll give a run for money of the private sector clinics. So obviously, people are willing to go to the public health system. If your system is good enough, good quality, people are willing to go. And if medicines are available, diagnostic facilities are available, healthcare services are available, people are willing to go. So the question why people are not willing or not going is for the simple reason that many of these services are simply not available. Even if they are available, they are available in partially here and there. And on top of it, long queues, and then not so good quality services. So all that has to be improved. Only then you. So it's not that we don't have examples. We have examples within the country. So let's look at those those states' model and replicate in other states. So that's the first point. The second point is about the primary healthcare challenges that the other person talked about. I completely agree with you. There's only one initiative that was taken along with. So if you look at Ayushman Bharat, so literally meaning that it's long live India. Now, there are two components of the Ayushman Bharat, right? One is the PMJ, which is the health insurance component. The other is supposed to be what is called the health and wellness centers. Now, these health and wellness centers are supposed to be one of the major primary healthcare center strengthening. But look at what is happening when it comes to health and wellness centers. 250,000 health and wellness centers were supposed to be set up by next year, 3 years. Even if assuming that that target will be achieved. Now look at, just go and see any of these primary healthcare, health and wellness centers. What has changed? The only thing that has changed is a board, the new board which says health and wellness center. The old board would say primary healthcare center. That's the only thing that has changed. Nothing really has changed. But the concept is good in terms of providing a comprehensive preventive and promotive, little including curative care services. The concept is good. But the problem is implementation, very poor implementation. So that's one thing. But this is very fragmented way of policy making. The reason why I'm saying is that with conviction. Now go back to 2005, which is still continuing, NHM, National Health Mission. So National Health Mission is one of the, I think they had a vision, very clear vision in terms of providing comprehensive care. But again, if you look at implementation across the state, some states have done well of NHM and some states have not done well. But I think over the years, last 15 years, things have did improve, and we could see some of the outcomes in terms of a number of people going to government facilities and so on and so forth. Things have improved, no doubt, but it's a long way to go. The governance need to improve, the quality of care needs to improve. But having said that, look at the public spending. It's still stagnant over the, over the last 35 years, just stagnant at 1% of GDP. This is simply not acceptable. A country which wants to become $5 trillion economy, in 2-3 years, how do you expect that a country is just spending very poorly on public spending? And look at all the health outcomes. We can only compare it with some of the sub-Saharan African countries in terms of outcomes. That's not where do we want to go. Sorry if I've been very cynical about it, but these are powerful things. I think during the pandemic, all of us are, in a sense, realizing the importance of why we need to really make public health system much more stronger. Over to you, Dr. Arun.
Thank you, sir, for answering these questions. So, sir, we have to wrap up this session since we are running out of time. We have another session from 12:30. So, on behalf of participants, FTP Organizing Committee, Ramanujan College, I would like to express sincere thanks to you for giving such an extensive coverage to healthcare system in India, highlighting relevant and knowledge-gaining issues like health financing, risk pooling, components of healthcare activities, coverage under various schemes and insurance schemes, and analysis of Pradhan Mantri Jan Arogya Yojana, COVID-19 and its impact, COVID-19 testing and its vaccination strategy, and the pricing of the medicines. Sir, I am sure that all the participants have gained and enlightened from your insightful lecture. This knowledge will surely imbibe the path of future research for all of us. I would like to thank you again for accepting our invitation to deliver lecture in this pandemic. We wish you good health and safer days ahead. Thank you, sir.
Thank you, Dr. Kumar, for that useful. I'm really thankful for the organizer to having me to speak on this. I wish I could speak more, but given the time constraint, I thoroughly enjoyed this lecture. And please do share the PowerPoint with those who need it, and they can use without any problem. No patents. They can use it.
Sir, we have already shared this with
All right. Thank you. Thank you very much.
Sir. Thank you very much.
Thank you, sir.
Thank you.
Ravinder, sir.